Welcome to Help Us program. Today we're going to take you CIIST 360 conference based on cardiovascular intervention imaging structure therapeutic on Sunday 14 July at Hyatt Regency Chandigarh. Heart diseases are increasing at an alarming rate, with many young patients in their 20s and 30s succumbing to heart attacks in India. This trend is a huge concern for cardiologists. World-renowned interventional cardiologist Dr. H.K. Bali said at conference. Heart Foundation organized a long-day academic program CIIST 360 to highlight the latest advances in the field of cardiology. Around 250 cardiologists and physicians from North India attend the conference. Speaker delivered lectures on cardiac disease, including coronary artery disease, structural heart disease, and heart failure. Dr. H.K. Bali, the founder patron of Heart Foundation, highlight advances in the medical field are now saving the life of heart patients, especially those with poor heart function, considered untreatable, or those in which traditional method could not be performed. He emphasized the importance of image-guided angioplasty using IVUS or OCT, which provides better short-term and long-term results. So let's see the shots of CIIST 360 conference held at Hyatt Regency, Chandigarh.
Gathering of members from the medical fraternity. This conference reflects our collective mission to push the boundaries of knowledge and practice in cardiology. The rising burden of cardiovascular diseases requires the need for innovative approaches to patient management, and over the next few hours, we will delve into exploring and sharing best practices that have the potential to transform patient care. Our diverse lineup of speakers will provide invaluable insights into the latest advancements in diagnostics, treatment strategies, and emerging trends in cardiovascular care.
Thank you so much, Dr. Bali, for this kind invitation. A lot of people in the hall have been inspired or trained by Dr. Bali. I also happen to be one of them. So it is a big pleasure to participate in my humble capacity in this educational meeting in the morning. So the task given to me is how to manage calcified coronary artery disease. So I tried to find 4 simple cases of calcified coronary artery disease which have some educational value and are all different. So the first case is a scenario where we have no options while we are treating the patient. The second is a scenario where we have limited options. The third is a scenario where the options are too many. And the fourth is a scenario where there should not be any other option. The wire had crossed this circumflex lesion, however, no balloon, a 1.5 balloon could not cross this mid-circumflex lesion. We should also note that it's probably a very small distal territory, not a very large vessel. So we tried to wire this vessel, we were able to wire, but the fine cross microcatheter would not cross this mid-calcified lesion. So we directly wired with a rotawire and started with rotablation, a 1.25 but because it was a very small vessel. So the 1.25 rotablation was done, as you can see on the right panel, across this calcified lesion.
All the parameters have been met and yet they don't respond. So in them, the first thing is to ensure they are getting effective pacing, which is what I was talking about. Check upper track rates, check Holter to see whether they are actually getting paced 98-99% of the time or not. Adjust GDMT. After that, the choices would be putting in a left bundle lead and converting it to a LOT CRT. That's one choice. Another choice would be to think of other structural therapies like LVAD or transplants. But I have, I think, 3 patients in whom I have done LOT CRT for this indication. They haven't had dramatic benefit, but they have definitely improved. And what has been possible to do, we can reduce the diastolic MR with programming. We can also ensure better LV-RV filling with programming. All that we can do. And usually, even if the patient doesn't reach the criteria of response, which is much more strict, it's a 10% improvement in ejection fraction and 15% reduction in LV and systolic volumes.
Know that there are 4 pillars of therapy which are essential. So I'll just discuss a few basic points. So when we look at beta blockers, we find that they are helpful or they improve the outcomes and reduce the mortality in practically every subgroup of heart failure reduced ejection fraction, irrespective of the NYHA class, whether they are diabetics, non-diabetics, the blood pressure. So beta blockers are useful in every subgroup of heart failure reduced ejection fraction. But there are few questions regarding beta blockers, that are all beta blockers the same, or is the mortality benefit specific to some particular beta blockers? What dose of beta blocker should be used, and what about NYHA class 4 patients, patients who are decompensated? Should beta blockers be used in these patients? So we know that all beta blockers are not the same. Like in the COMET trial, carvedilol was compared to metoprolol tartrate. That is not the sustained release metoprolol, that is the usual metoprolol. And what was seen was that carvedilol was superior to metoprolol tartrate. Similarly, in the BEST trial, bucindolol was not shown to have any mortality benefit. So that beta blockers which should be used or which can be used are carvedilol, bisoprolol and metoprolol sustained release, or metoprolol succinate. So none of the other beta blockers have been shown to reduce mortality in heart failure, reduced ejection fraction. These are one of the 3 beta blockers should be used. So what about NYHA class 4 patients? Often there is hesitation in using beta blockers in patients who are NYHA class 4. So the Copernicus trial addressed this question, and this was basically in NYHA class 3 and class 4 patients. So this was over 2,000 patients of both ischemic and non-ischemic, and it compared placebo with carvedilol. And what was seen was that beta blockers or carvedilol reduced mortality even in this 6 subgroup of patients. In fact, the reduction in mortality was massive. It was a 35% reduction in mortality even in NYHA class 3, class 4 patients. And what was seen was that even in very sick patients, they tolerated the beta blockers very well. The withdrawal from carvedilol was 13%, withdrawal from placebo was 16%.
It means is that if there are ectopics, multiple ectopics, and they're becoming worse and starting at a drop, what are the options? First and foremost, we need to look at metabolic factors. It may be potassium, it may be magnesium. So those are the factors we need to find out. It could also be ischemic. So try to look for reversible components, reversible factors which are causing arrhythmia. And if you are able to control them, then that is the way to go forward. If you are not able to control, then you might have to take help of antiarrhythmics, depending on which particular antiarrhythmic you want to use, and then go on to the rest of it. First and foremost, you try to find out why are there so many topics which you're talking about, right? And as Dr. Ajay very rightly said, that we should start these 4 pillars at the earliest. So stabilize those patients. Once they are hemodynamically stable, then you can start this. Beta blockers are extremely useful. You can start them quite early. SGLT2 inhibitors you can start very early. The other 2 pillars can wait before the discharge. But you need to get on these on board as fast as possible. So try to find out the alkylic components and then go. And an honor to present some of the interesting cases which we've done in the last 10 years, last one year. And I would like to say that when we do such complex procedure, team is most important. It includes interventionists and a host of interventionists, because you need a lot of discussion before carrying out such procedures. You need cardiac surgeon to talk to, you need cardiac anesthetist and an intensivist. A lot of role is played by nurses and technicians in the cath lab also. And I have always been privileged to have a wonderful team of cardiologists working with me and the support staff in our ICU and the cath lab. And the cases are a combined effort of all these people. So my first patient today is an 83-year-old male, a doctor by profession. He was a diabetic, hypertensive. He presented with recent onset of angina, and he had rest angina for 2 days. Each episode lasting for a significant amount of time. But pain was relieved by nitrate. He had previously undergone a PCI of the Osteolast CA, which was about 12 years back. And on ECG, we found that he had ST segment depression in 2-3 area, V5, V6. Echo showed an ejection fraction of 45%. There was a mild MR, and RCA was hypokinetic. Creatinine was elevated, 1.5 milligram percent, and drop was also elevated slightly. So the diagnosis of acute coronary syndrome, non-ST elevation myocardial infarction, he was taken for an angiography. Angiography showed a near total occlusion of the right coronary, a left main and left main bifurcation stenosis. So we took him for a right coronary angioplasty. And what you see in this right coronary angioplasty is that there is an acute and chronic total occlusion. The stent in the proximal part of the right coronary, ostial part of the right coronary, is underexpanded. We were able to cross this lesion with a filter XT wire, and we did balloon dilatation, and then we repeated, we did an IVUS. We did an OCT, and OCT showed very interesting findings. It showed an underexpanded stent, it showed a calcified nodule, and an ulcerated plaque. I'll just go through that. And then we did an angioplasty with a high pressure balloon dilatation. Getting balloon down was a little tougher. So we used a guideliner to do an angioplasty. And then we had to use a cutting balloon, 3.5 millimeter distally, and we had to do a cutting balloon in the proximal part in the calcific nodule. And we repeated an OCT after that. Still there was an underexpanded stent in the proximal part with the OCT, and then we used an IVL. IVL in the distal part, in the calcific nodule part, and IVL inside the stent to get an optimal dilatation of the previously deployed stent. This is a 3.5 and then a 3.5 millimeter balloon. And finally, the OCT showed that we have got a good bed preparation. And then we deployed stents, 2 long stents to take care of that. And this is what the final result we got on the right coronary artery. So OPL, cutting balloon, IVL with image guidance, and an underexpanded stent on acute and chronic heavily calcified vessel. But we were not done as yet. We had to use, this is the final result on the right coronary. And OCT showed that the stent was nicely expanded. Then a couple of weeks later, we got him back for the left main bifurcation angioplasty stenting. The LCX angle was very acute. We had to use an angled microcatheter to get into the circumflex. And then we did a balloon angioplasty of the mid-LAD, which was heavily calcified. Did a cutting balloon in the proximal part of the circumflex. Repeated a IVUS. There was a circumferential calcification, and we did IVL in the mid-LAD and deployed 2 stents. Did a DK crush technique in the left main bifurcation, and all steps for the DK crush were done. And repeated the IVUS after that. Because I've been told the time is short, so I will rush through that. And this is the final result we got on the left side. So left main bifurcation, heavily calcified LAD, and the right coronary I have already shown you. A stage procedure gave a very good result on this. A 67-year-old doctor, reasonably straightforward looking angioplasty, but it was a very difficult nightmarish experience of 2 weeks in the CCU. He came to us with an interior myocardial infarction, with an ST elevation myocardial infarction, but it was a delayed presentation, 48 hours. He continued to be in LVF and had intermittent angina. ECG showed a persistent ST elevation in one AVL V1 to V6. Echo showed an ejection fraction of 28%. LAD was hypokinetic, there was a mild MR. He was taken up for angiography, and angiography showed that there was a total occlusion after the second diagonal. And proximal part of the disease, LAD had an ulcerated lesion. What is interesting to note is that in the left PDA, and if you can see the left PDA part, there is a lesion which we thought we could manage subsequently after we had taken care of his acute lesion. So we did an angioplasty stenting of the LAD. This is the non-dominant RCA. LAD of the angioplasty of the LAD was reasonably straightforward. We did a good bed preparation. After that, we deployed 2 stents in the LAD. You can notice the guide wire being placed in the diagonal. We got good result in the LAD. Repeated in IVUS. It showed good apposition, the diagonal flowing. And we thought that we're done, but we only need to take care of his LVF. And we put in a IVP on him and send him to CCU. Over the next 4 days, he continued to have recurrent VT, and he went into VT stop. We did everything which was possible to take care of that VT. Multiple drugs, amiodarone, Xylocard, Mexiletine, Sotagard. Nothing could control that, and each time he would have a DC, VT, he would require a shock. And he almost had 100 ventricular tachycardia episodes over a period of these 4 days. So we were a little perplexed what to do. All reversible components were taken care of. So we decided that despite the indication for an ICD after 40 days, he was getting shock. So let's put in a DC, ICD and see what happens. But we put in ICD, but he continued to have shock, and the shock ICD was delivering multiple shocks. Then we looked at the angiogram again, and we thought that maybe we're dealing with that dominant LPDA stenosis, which is causing an ischemic VT in this particular patient. So we went ahead and did an angioplasty stenting of that LPDA, and after that there was no other VT. So the moral of the story we learned from here was that we should not leave ischemic VTs in such patients. We are prone to believe that all such episodes may be because of the scar which was in this particular patient, and after we taken care of the culprit vessel, the patient would be stable. But this patient, we had to take care of the circumflex, and after that there was no recurrence of the VT. Now, 80-year-old male, recent onset of angina, crescendo, normal LV function, no regional waist wall abnormality, TMT strongly positive, and angio was done an outside hospital elsewhere, and it showed a severe calcific right aortosteal critical lesion. And if you can see, I think the technology is not working. So we were able to, this patient had a critical aortosteal stenosis. The calcium was extending into the aortic valve extensively, and we had to use multiple technologies to take care of this critical aortosteal stenosis.
Inviting me, and I'm sorry I couldn't be there physically, but I thought I must participate, so here I am with you. We're talking about atrial fibrillation in this talk today. First of all, I just want to tell you that whether you are an interventional cardiologist, whether you are a structural heart disease specialist, whether you are an angioplasty, or a clinical cardiologist, or you are an intensive care doctor, or you are a physician, you can't get away from atrial fibrillation, because atrial fibrillation is one of the most common arrhythmia in the world today. As the age goes on increasing, the incidence of AF goes on increasing. by the time you reach 80, almost 8 to 10% people will have atrial fibrillation. So you can understand the quantum and the quantity of problem in atrial fibrillation. And if you go to any meeting in the world, the arrhythmia meeting, heart rhythm society meeting, almost 30 to 40% time goes for atrial fibrillation. So first of all, we used to believe that atrial fibrillation is a benign arrhythmia, which is not so. There is more mortality, there is more stroke, it causes dysfunction, it causes heart failure, it causes cognitive decline, vascular dementia, there is depression, impaired quality of life, and more hospitalization. And atrial fibrillation leads to heart failure, and heart failure leads to atrial fibrillation. Well, when we talk about the past many 2 decades of story, we used to have the question of whether we want to do the rate control or we want to bring back to normal rhythm, and all those trials done in 80s and 90s and 2000, there was no difference between the rhythm control and the rate control philosophy. Basically, we didn't have medicines who can keep the patients in sinus rhythm. So if you see some of this data, for example, if you see this, most of the patients were not in sinus rhythm. 10 years back, I myself was not believing in atrial fibrillation ablation, but now the technology has improved to a point that we should consider this therapy in many patients which can be benefited by this procedure.
So, sir, there are some questions from our side. Number one, is cryoablation being now practiced in your lab or anywhere in the country for atrial fibrillation? Number one.
Cryoablation is available in the country, and I am not a great supporter of cryoablation because the success rates are not more. The cost is very high. Like we do this ablation with the Cardo system around 4 to 4.5 lakh rupees. The cryo will 8.5 to 9 lakh rupees. The results are not superior, and some of the patients after the cryo will again have to do the standard catheter. Yes, one of the biggest advantages is that it increases the procedure time to practically half. There are I think 8-9 centers in India now which have cryo. I am waiting for the pulse field ablation to be available. That will be my first choice to acquire.
And in pulmonary vein isolation, sir, how many pulmonary veins do you target at primary at the first attempt? Is it all, or is there any?
Well, our aim is to all the 4 veins. But sometimes if the right pulmonary vein is very awkwardly located and it's a standard proximal AF, you may not do that, but our philosophy is to target all the 4 veins.
And finally, sir, who are the patients you think should be primarily tackled upfront, considering the success of this procedure now in experienced hands? And do you also feel that this is a technique which, I don't know, we are made to believe maybe future holds something else, that this may come into the domain of interventional cardiologists as well, who may not necessarily be electrophysiologists?
I think excellent question. Those questions are really excellent. I think first of all, patients who should be referred to for AF ablation are one group is the best group is the proximal AF with almost normal heart. When I say almost normal heart, means they have hypertension, their left atrium is around 4, maximum 4.5, 4.2. They have multiple episodes of AF. And like if the AF has been present for more than a year, in a year you have 3-4 episodes already, I think those patients should be offered AF ablation because success rate is best in those recurrences are the least. Then the second group which we are very aggressive to do ablation in patients who come with heart failure. Because in heart failure there are more than one trial to show the advantage of AF ablation. The Cabana as well as the other trial, these patients really do well if you ablate them, the heart failure will do. Actually, the patient who come to us for CRT-D or CRT-P therapy, and if there is a story of intermittent paroxysmal AF or they have AF, in these patients, we practically always do the AV node ablation because the efficacy of the CRT in many patients, the AF is less than ideal. So we upfront do the AV node ablation in the patient, and believe me that these patients they do much better after AV ablation and CRT rather than just CRT.
Very nicely, and I am sure you would have also enjoyed it as much as I did. I would like to thank all the faculty members who came from different parts of the country, Dr. M.K. Das, Dr. Atul Mathur, Dr. Arun Chopra, and Dr. T.S. Kale could not make it in person here because it was his birthday, and so therefore he was very keen to deliver the talk. So I'm grateful to all the speakers who made their presentations. I'm grateful to all the delegates who have come from different parts of the country, especially the adjoining states. Some came from Jammu and Kashmir, some came from Punjab, Haryana, Himachal Pradesh, some part of Rajasthan, and I'm sure they would have benefited from deliberations in the conference. I'm also thankful to Chandigarh Physicians Forum, which was a very, very important part of our conference, and their participation in different ways is laudable, and I thank the President and Secretary of Chandigarh Physicians Forum for partnering with our conference. I also want to put on record my sincere thanks to all the senior faculty members. Dr. Suri is here, who took out time from their busy schedule to be with us. I would like to express my thanks to the Livasa organization, Dr. Pawan in particular, and all other senior faculty members and senior members from the NPC staff who are a constant source of support and help during the formulation, the conceptualization, and during carrying out each aspect of this conference. And I am sure they would continue to support such academic features in future as well. I also want to put on record my thanks to the industry, without whom it is not possible to do academic procedures as much as we would like to do. And each one of them was a great help. I would also like to put on record my thanks for the staff of Hayat, which was particularly Mr. Ashwin, who is a source of help and is a great friend, and we have been troubling him for asking for outlandish demands, and he has been always forthcoming in helping us out. And most importantly, I would like to thank the team member, my team members, who have been working day in and day out for the last about almost a month to put this thing in shape. And sincere thanks to all of them, and a big hand to all of them. Cheers, keep it up, keep the good work going, and I am sure that we will keep on improving. There is no limit to what you can improve. You may be doing a great job, but there is always scope to do that little bit better. And we can inculcate that habit of always, every time trying to do that little bit better. We will be much better in coming months and years. So you please keep on rocking. So with those words, I would like to say that this was a small effort to try to interact with physicians of this region and make them aware through lectures, discussions, and debates that what advances are happening worldwide and how can we utilize those to help our patients. I ultimate focus is betterment of our patients. Ultimate focus is getting the best technologies at affordable price to the last man standing in our region. The ultimate focus is to prevent heart disease. If all of us can join hands through these conferences to make that happen, that will be a great thing to do. So thanks a lot to all of you, and we look forward to your continuing support in coming months and years, and we intend to hold this conference every year, and we would be announcing the date of the next conference very shortly. Dr. Pawan, would you like to say some few words?
Out here, but a lot goes in the background with regard to conceptualization, planning, working with the industry, trying to identify the speakers, the delegates, and getting everybody here. So I must commend Dr. Bali, his entire team and team of Livasa working together for making it happen. We are committed to continuing our academic prowess with all our clinicians, and will continue to support such academic initiatives going forward as well. I think we discussed a lot on cardiology. As an avid medical student, I was more than a decade back, I felt I went back to classroom today. I learned a lot from so many faculty members, so I am thankful to Dr. Bali for having me here. Initially I was hesitant that I will be attending the Sunday session as well, but I think I got educated. So thank you so much for having me here. And it is our commitment that we intend to bring all this science to the people at large. A lot of this science is available to people in tier 1 cities like Delhi, Calcutta, Hyderabad. At Livasa, we intend to bring the same level of care to tier 2 and tier 3 cities of this country, not just the tier 1 cities like metros. And we remain committed to it. So with this, few words. Thank you, Dr. Bali. Thank you everyone for being here. Thank you so much.
तो किस तरह बढ़ा सकते हैं, किस बैटर तरीके नाल असीं पेसमेकर लगा सकते हैं ताकि ज़्यादा मरीज़ां नूं ज़्यादा फायदा होए, उसदे बारे च असीं गल कीती। तो ये सारियां जिहड़ियां बीमारियां दा लेटेस्ट डेवलपमेंट है ਉਹਦਾ ਅਸੀਂ डिस्कशन की। ਜਿਹੜੇ ਇੱਥੇ ਡਾਕਟਰਸ ਆਏ ਸੀ ਉਹਨਾਂ ਨੇ ਸਵਾਲ ਵੀ ਪੁੱਛੇ, ਉਹਨਾਂ ਦੇ ਆਪਣੇ ਜਿਹੜੇ ਐਪਰੀਹੈਂਸ਼ਨ ਸੀਗੇ, ਉਹ ਆਪਣੇ ਮਰੀਜ਼ਾਂ ਜਿਹੜੀ ਚੈਲੰਜਿਸ ਫੇਸ ਕਰਦੇ ਆ ਉਹਦੇ ਬਾਰੇ ਸਾਡੇ ਸੀਨੀਅਰ ਫੈਕਲਟੀ ਨਾਲ डिस्कशन की, ताकि ਸਾਨੂੰ ਲੱਗਦਾ ਹੈ ਕਿ ਇਸ डिस्कशन ਕਰਕੇ ਡੈਲੀਬਰੇਸ਼ਨ ਕਰਕੇ ਉਹ ਜਿਹੜੇ ਉਹਨਾਂ ਦੇ ਮਰੀਜ਼ ਹੈ ਉਹਨਾਂ ਨੂੰ ਬੈਨੀਫਿਟ ਹੋਊਗਾ। ਉਹਨਾਂ ਨੂੰ ਜਿਹੜੀ ਲੇਟੈਸਟ ਟੈਕਨੀਕ ਅਵੇਲੇਬਲ ਹੈ, ਲੇਟੈਸਟ ਤਰੀਕੇ ਨਾਲ ਉਹਨਾਂ ਨੂੰ ਯੂਜ਼ ਕਰਨਾ ਚਾਹੀਦਾ, ਉਹ ਆਪਣੇ ਮਰੀਜ਼ਾਂ 'ਚ ਉਹ ਅਪਲਾਈ ਕਰ ਸਕਦੇ और ऐसे सेंटर च रैफर भी कर सकते हैं जिथे ये टेक्नीक अवेलेबल है। तो वो बारे असीं गल की। मैनूं लगता है कि सानू सारे तरीके गल करनी चाहिए हार्ट के मरीज़ों के बारे। सब तो पहले गल करनी चाहिए कि असीं रोकथाम किस तरह करिए, प्रिवेंट किस तरह करिए। बट अगर किसी ने बीमारी हो गई, दिल की नाड़ियाँ हो गई या हार्ट मसल कमज़ोर हो गया, तो मैं कहना चाहूँगा कि अज के दिन साढ़े कोल ऐसे टेक्नीक अवेलेबल है, ऐसे दवाइयाँ भी अवेलेबल है, डिवाइसिस भी अवेलेबल है, एंजियोप्लास्टिक प्रोसीजर, इंटरवेंशन प्रोसीजर अवेलेबल है, जिस करके असी किसी भी स्टेज ते हार्ट की बीमारी का इलाज जिहड़ा वो कर सकते हैं और पहले कोलों अच्छे रिजल्ट दे सकते हैं। ये साइंस प्रोग्रेस करती रहती है, नवे टेक्नीक आते रहते हैं, असी कॉन्फ्रेंसिस करते रहेंगे, जिहड़े डॉक्टर्स उन्होंने नॉलेज ऑगमेंट करते रहेंगे ताकि अल्टीमेटली पेशेंट्स नूं फायदा हो।